Hi there guys, and welcome to today's live stream. We're going to be talking all about hip impingement, what it is, how it's working, and more importantly, what you guys can do to fix it. If you are new to the channel, please do consider subscribing. We do these live streams every single weekday. And with that being said, let's get into today's topic on hip impingement. So today's topic, hip impingement. We've got a good bit to cover. Hopefully you guys are going to find this really helpful. I know that a lot of guys in the back in shape will notice at some point or other there are certain exercises that cause this little flicking or clicking or clunking in and around the sort of the hip area, front, side, back, etc. And we really want to explain this because a lot of times people get caught up, oh, is it bad? Should I stop? What's going on? And I think hopefully today's live stream will really sort of dispel that and give you guys a bit more confidence in terms of what exactly is going on and how it can really sort of how we can get around it, so to speak. So first and foremost, this is actually a really common thing. People, the same as most cases of back pain, there is that sort of isolationist element to it. People think, oh, it's just my body, it's not going right. No one can really see that anything's wrong, but I feel it when I'm doing these things, and it's really disconcerting. And that is really the main thing around this sort of snapping, clicking sensation that we get in and around the hip. It is that disconcerting nature to it that it really throws us, makes us feel a little bit worried about something clunking and clicking in that area. We can't see what it is, we don't know what it is, and unless you've got a detailed, good anatomical understanding, you can't really dispel all the different things it could be that are probably concerning you and keeping you up sometimes at night because you don't know what's going on. And once we figure it out, it really makes things an awful lot more comforting and really helps you guys understand. Now, I've got some drawings on the board which I'm going to go through. These are both front-on images, so I'm going to go through those in quite a bit of detail. We'll do a bit of drawing on the one side and a bit of annotation on this side as well. But essentially this, as I mentioned at the outset, can be on the side or on the front. And now, before I get into the details here, if you guys have questions as we're going along with this about your particular occurrences of this, and please do post those in the comments below because we're going to get to Q&A at the end anyway. Lara's reading through the comments and keeping an eye in there, so she'll be able to read those out as we get to the end of the live stream. So there's two real variations here. We've got snapping hip syndrome, and then we've got femoral acetabular impingement, and those are these two up here. Now, with regards to the presence of these two, I'm going to break them down. Femoral acetabular impingement on this side, and then the snapping hip syndrome on this side. And it sounds horrible, snapping, but it's more of a snapping noise, not breaking snapping. So please bear that in mind. Now, the other thing we can get is quite often there will be a combination of both of these occurring at the same time, and that's really quite important. So if we start out by kind of going through with the right pen, hopefully, what is actually going on in this area. This is the hip, and we're looking at from the front, obviously the one hip here, and what we've got is essentially we've got the head of the femur, and then we've got this little bony bit. Now that's out on the side here. You'll feel that it's the hard bit, a little bit lower down. We've got if we extend this out up here, you'll feel that sort of our waist, so to speak. Now, this bony bit here is called the greater trochanter, and we'll come back to that in this one here. But when we're talking about femoral acetabular impingement, what's essentially happening is the nature of the hip is that it's a very stable joint. This is why in the back in shape we get you guys to work on that hip range of motion in the early days to keep them flexible, because it can really take the load off the lower back in all ranges. So it really helps. But what is necessary is we have this narrow neck of the femur, and that means that when the ball comes up like so, this bit here, this bony bit here in the socket, can fit neatly into this part here, and that allows us a good range of motion, a good natural range of motion. And if that's all intact, then everything works nicely. But when it comes to femoral acetabular impingement, there can be two little variations. One is called a camshaft, and I'll explain that, and one is a bit more of a pincer mechanism. And these basically mean that there's a deformity either on this part here or on this part here, that in a lot of cases, especially with what's called the camshaft, so I'm just grabbing this to rub this off. The camshaft, you'll have had that your whole life. That's just the way you've developed. And to be completely honest, when we do a lot of x-rays, we capture the hips because we want to look at leg lengths. And when we see those hip sockets, you actually see, oh, this person, the radiologist might reply and say, this person's got a camshaft, and you can see it. And I'll explain what that is and why it's relevant. So the camshaft, first and foremost, helps create the notion of impingement. It helps you more likely to impinge on that hip. And that's basically where, instead of going in nice at the neck here, it's more straight like that. So now all of a sudden, as the hip comes up, it hits this bony bit first. And this can be a bit uncomfortable if we're repeatedly doing this at certain ranges of motion. But this is the camshaft. So then things can start clicking and clunking, and it just affects the bony architecture of that joint. The second one is what's called the pincer. And this can also develop with osteoarthritis in the hip, and that's something to bear in mind. This one here, this camshaft, CAM, deformity, which is type 1 if you will, is going to be there since birth. But the pincer could arguably be there since birth, but it could also be a degenerative change. It could be that osteoarthritis in this joint can cause it to enlarge, and now we have very little movement before these two bony bits hit one another. And this is the same as with our elbow. Our elbow, as we go there, it's bone on bone. As we come this way, it's just muscle stretching, nothing's hitting. Well, in the case of femoral acetabular impingement, it's things are hitting, and there are lots of soft squidgy bits around here as well, and those can be irritated in this process. So it's something that we need to bear in mind, and this can firstly create discomfort and pain and discomfort in this region of the hip and inflame the hip joint. It's worth mentioning, and I'm not going to get into this in too much detail unless you guys have specific questions, but if we are irritating certain parts of this hip joint, it can sometimes refer pain down to the knee. So that's something to bear in mind. So that's that part. But this can then make the snapping hip syndrome, which I'll get into in a moment, a little bit more pronounced because we have different bony architecture. Now, if you've got any questions on that bit, do please post those in the comments below, because this is affecting the bony architecture for femoral acetabular impingement. Now we get onto snapping hip syndrome, and you'll notice I've got these red lines coming across the same part of the hip. These red lines essentially make up the muscles. We have some of the quad muscles like rectus femoris here. We have some of the glute muscles and the IT band coming around here on the outside and back part of our hip region, and then we've got our psoas muscle, which comes in and around here. Now all of these muscles come very close to the joint, very close to bony prominences, and this I think is much more common, and this is what a lot of you guys are seeing. And when we talk about doing some of the exercises like the dead bugs, for example, as your leg's going out, you go snap, clunk, click, whatever it is, however you would vocalize that, but it comes from somewhere in here, in the hip here, and that's what really is causing the symptoms, the noise, etc. And again, it's not particularly painful, generally speaking. So first and foremost, it's these tendons are flicking over different parts of bone, and that over time can create a little bit of inflammation. It can create a bit of bother, but it's either going to be your psoas muscle coming around the front, it's going to be your rectus femoris coming off the front of the actual hip joint, as your head of the hip here, head of the femur here, the tendon will kind of go boom off to one side, snap, boom off to the other side, snap, and that's going to create that snapping sensation. And then around here it's the same. Looking at you from the side, we have coming down, so as we look at you from the side, the hip is here, and then your ball is here, and if we're looking straight side on here, the tendon, this one here, comes straight down the side here, and this bit sticks out, this bony bit sticks out. So again, all that's going to happen is the tendon's going to flick one side or flick the other, and that can give you pain on the actual side of our hip, the side bit that we lie on when we're sleeping, and that can make sleeping uncomfortable. Then we notice things like bursitis, what's called greater trochanteric bursitis, which is a little fat, fluid-filled sac here, which gets irritated at this process. Now, that's pretty much what's going on in these two syndromes, if you will. And I mentioned with certain exercises, if we play around with the angle that we're moving our leg at, we're going to find that the snapping or the flicking or the clicking goes away momentarily. But what is the sort of the plan of action when it comes to actually dealing with this? Because sometimes it becomes painful. Those tendons actually get inflamed because they're constantly being flicked, and it gives us pain. This is much less common because it is really an asymptomatic thing that we notice. We hear the clicking, but it's not overtly painful. And once you understand this, it really can set your mind at ease that there's no great skeletons in the closet that are causing something a little bit more sinister. But what we do find is there's two real methods. One of them, which I'll address first because it's nice and short and sweet, is that they use surgical intervention to stretch out these muscles and tendons. Stretch out, notice I said. And that is much less common. the overwhelming majority of cases, they will start off doing some stretching work physically. You can do this. And I suppose the real good news here is a lot of you guys that watch our YouTube lives and our Facebook lives are in the Back in Shape program, and you're going through that protocol. And the great news is you're doing that already. As you go through the phase 1 and into particularly the phase 2 and latterly phase 3, we're strengthening up all of these muscles here. But also with the addition of the flexibility program, we're making objective improvement in all of these muscles and their length. So if we make a diligent effort with the flexibility protocol as we move into phase 3, and as these muscles get stronger as well, we're going to find that the symptoms of this will be managed much, much better and may even disappear more or less completely. So it's something to bear in mind. The research looking into this really goes down the route of saying conservative management, increase the flexibility and the length of these muscles so they're not being exploited as much, and you're going to find that the symptoms abate quite well. Therefore, you're already doing that anyway. This was more of a coincidence more than anything else, to be completely honest with you guys, but it's great news for those of you that are in the Back in Shape, especially if you do suffer with this and you're moving into phase 3 and the flexibility protocol. So with that out of the way, I think we can move into Q&A if there are any questions.
Okay, awesome. Good morning, everybody. Happy Friday. Can't
Yes.
believe it's already Friday. The week seems to be flying past. Please do keep your questions and your comments coming in. So, Mike, we were just discussing before we went live that I actually do get this snapping sensation on that tendon going straight down the front.
Yeah.
So I get that doing the dead bug. So what would you recommend? Just changing the angle of
Yeah, so
the leg?
that's the real common one. I get it as well on my right hip when I do the dead bugs. You just have to play with the angle. So, you know, your legs normally going out. If I look straight at you guys, your legs kind of going out, one out and then the other, one out and then the other. If you kind of just play around with a little bit and go maybe slightly out to the side, or maybe you point your toes out a little bit or in a little bit, you'll find that it just slightly changes the angle here. One thing I haven't really touched on much in this video so far is really talking about we often find that there's a little bit of a torsion in the pelvis, or maybe one leg is longer than the other, and that is going to create a twist, or it's going to create slightly different architecture or slightly different bony positions, and that again is going to put certain muscles running across a different path, a slightly different path, which means they're more prone to flicking off to the one side. But a lot of that is due to asymmetry, etc., in those muscles. And we talk a lot about, especially in the Back in Shape, about doing things symmetrically. You may notice that one side is a little bit weaker than the other, or one side is a little bit more stiff than the other, especially as you move into the flexibility protocol in phase 3, when we're challenging some of these hip muscles a little bit more physically. But there's no point doing 1,000 reps on one and 10 reps on the other. Just slowly work on building up to symmetry, and as they slowly improve, you'll find that the one catches up to the other in both mobility and in strength. Trying to trick the system by doing extra work on it is really often counterproductive. We don't. It's very difficult for us to do that. So just work on symmetry, and you'll find that these things tend to start to straighten themselves out. It does take time. There's no two ways about it. It's not a change that's going to take place over a couple of weeks, but it is the sort of thing that can really have a beneficial effect if we build it over time.
Okay, awesome. Got some questions coming through on YouTube and on Facebook. Just firstly, a comment from Ollie. He said, I used to get the clicking and the clunking sensation all the time and doing the dead bugs.
Yeah.
But as my muscles got stronger, I just don't get it anymore.
Yeah.
Fantastic. Alex Sparta said, sorry, I missed the beginning. I have a clunking noise more than a clicking at times, and I just cannot get rid of the noise on my right leg.
Yeah, it'll be this. It'll be that's exactly what it'll be. Clicking, snapping, clunking, flicking. Different people use different terminology here, but the things that are doing that, it's really, really quite common, and it's one of those things where over time, as I said, a lot of people, depending on what stage in the Back in Shape you're at, you haven't really gone through the stretching work, and we wouldn't encourage you to do stretching work if you're in phase 1, because we don't have the strength to accommodate that. We'll end up just going to stretch out the muscles, and then we've got weakness in those muscles, which is not going to be able to deal with that extra mobility. So we have to do things at the right time. The clunking, the clicking, the snapping, whatever we want to call it, in that hip region, front, side, back, etc. It will abate with time as we go through that process. It's just one of those things that if it's been there for a long time, or maybe we haven't done exercises that have shown that the problems have been there for a long time. We've only just started noticing it when we've done some of these exercises. It is something that will go away, but we have to go through. Again, it's very clear what the research is and what the line of inquiry or line of treatment is here, and it is that conservative stretching, etc. And then it is the surgical work is just surgically doing what you could have done yourself, but quickly. And Those sorts of shortcuts tend to lead to problems, I think, because easy come, easy go, and we haven't necessarily dealt with everything else. We can go in and surgically decompress a muscle, but how does that affect the tendon? How does that affect the receptors that were there, that were telling the tendon to do one thing or overriding those signals? Getting in and starting to just disrupt an area is I would say unwise, unless we've really given it a good concerted number of months of specific protocol. And that's why I think anyone that goes through the flexibility protocol, it's 12 weeks, you will make a change in the hips, you will make a change in those muscle lengths, and that's really at the time that you need to give it to actually make some improvement. If we're changing any short of that or not doing it properly, then we're only cheating ourselves, unfortunately.
Okay, also, I'm really glad that we're covering this topic because I think it's just so important, because we've had so many questions.
Yeah, I know, we get questions all the time in the clinic and also over on the Back in Shape.
Okay, I'm just going to jump into YouTube. Sarah Ann has asked, I'm awaiting a right hip replacement due to the hip collapsing. Exercise is greatly reduced. Is there anything that I shouldn't be doing whilst exercising? The noise my hip makes is horrendous.
Yeah, so I haven't covered that one as much because it tends to be much less common, but we do have instances like that where we've got there's different types of, there's external and internal snapping hip syndrome, which relates to certain tendons. So the one is going to be this tendon out here and the other is going to be these tendons that are a bit more internal. Then you've also got the intra-articular, where there's actually serious degenerative change or damage to the bony articular surfaces, but you would have known about that. That would have been diagnosed on some sort of typically X-ray imaging or MRI imaging, and you would really know what's going on there, and there would generally be some sort of cause to that you could attribute, rather than it's just happened for no reason, because that is severe damage, as we're waiting for in that instance for a hip surgery. The thing I didn't mention as well is that hip surgeries will affect this, so you will commonly get this after hip surgery, and you might be quite concerned by that, especially if it's not been spoken about by the hip surgeon. But it is something, it's the same set of things, it's just that your bony architecture will have a bit of titanium in it, and that's going to just slightly change the way in which these tissues have been disrupted. And don't be alarmed if there is a bit of this snapping sensation afterwards, where it is the tendons flicking over that titanium or flicking over the slightly new anatomy. That's okay, but it is something, and what I would suggest prior to the surgery is doing what we can to improve the quality of the tissues around that area.
Yeah.
It's all too often tempting to just do nothing. But doing nothing is going to lead to contraction in these soft tissues, it's going to lead to weakening in these soft tissues, and that's going to make your rehab after surgery much, much more difficult. I would hope, I really would, that the guys you've been speaking to would have given you a little bit of guidance and said, look, let's try and get these muscles. I know it's painful, it's going to hurt, but it's already damaged and it's being replaced. So if it gets a little bit worse, how much is that really going to mean? Because you're going to be getting rid of this stuff anyway. But actually they would hopefully have given you a bit of guidance. Doing prehabilitation before surgery always helps post-surgical outcomes. It's just more difficult because of the pain.
Okay, awesome. Hope that helps, Sarah. And Alex Sparks has followed on. She just said, if I really clench my abdominals, I can lose the clicks on my left leg. So
that's just a case of actually getting those muscles engaged properly. So that's a really good sign that as you get stronger, you're going to find that the clicking and clunking goes. It's a combination of strength and flexibility, and we cannot do one without the other. And unfortunately, people tend to move into the flexibility instead of the strengthening as the first port of call. But this is quite often the wrong way. And you've got an example right there, which is great. That by really focusing on overly strengthening the area, overly protecting the area, we can eliminate some of these symptoms, and that's a very good sign.
Okay, awesome. Karen has asked here, sometimes I find that I get stiffness in my hips when running. Should I start stretching before or afterwards?
So we haven't gone into too much detail, even with the flexibility protocol, but there's a bit of background information that went into the flexibility protocol as well. And doing dynamic stretching before activity is going to be better for you. So that's those sort of leg swings, those gentle leg swings to get things moving more effectively through the hip beforehand. Doing the static stretching is not going to be a good idea to do right before your runs, because that quite often will lead to increased likelihood of injury. So dynamic stretching before a run, just getting those hips going through a nice full range of motion, like 30 seconds of a leg swing, for example, can be quite helpful. But don't do static stretching. That would be bad. Afterwards, yes, not before.
Okay, Sally said, very interesting. I don't get the clicking or the clunking, but sometimes when I was able to walk more, sometimes felt a tightening, restricting feeling at the front where the leg joins the body. Also used to feel this when doing the dreaded knee hugs, where the restriction to the hug was the feeling of uncomfy squashing in the crease. Is this a muscle tension tightness? Thanks.
It's difficult to tell. I think for you, Sally, you're going to find out pretty soon, I suspect. But it may well be there's an element of femoral acetabular impingement. It may be that the bony architecture just means that certain ranges of motion we can't do it. But if we've got CAM, which is this thing here, then that's the shape of your hip. We can, and this is where people fall foul when they try and just do flexibility work. It ain't going any further. It's going to go that far, and then the soft tissues are literally hitting one another. Much like if I do that, it doesn't go any further because this soft tissue is hitting this soft tissue, and it's creating a cushion. And if I try and press it more, I'm just going to hurt myself. So it could well be that. It could well also be there is a little bit of tension or inflammation on the front of this psoas tendon. But I think with regards to the bony architecture, we'll have some answers for that hopefully very soon.
Okay, awesome. Rita Katz is on. She has said, I get pain in my right groin, i.e. impingement, and at times soreness down the inside of my leg. This is always on the right side. Is this related to the different injuries I have had, torn hamstring, running, severe bruising, coming off the bike?
That's difficult to say because that could be a bit of psoas here because this is basically coming through your groin, so it could be that. And if we're on a bike, for example, for long periods, or even at a desk for long periods, that psoas muscle is going to get pretty tight because it's tight all day, it's shortened all day, and how you use it is how it evolves and develops. So it may well be that psoas is pulling a little bit on the front of the hip, and that's what's giving you a bit of that groin pain. But it could also be if we've had hamstring strains, if we've had quad strains, if we've had glute strains, etc. It could well also be the fact that we've got some adductor muscles which maybe have been overcompensating, coming through the middle of our groin, coming down the inside of our leg. It could be that some of those guys have been just working a little bit too hard. And quite often we find with the vibration, I don't have the gun in here at the moment, but the vibration gun over those adductors is terribly sensitive. It is really, really sensitive when you do it, almost to the point where it's difficult to bear. Not painful, but just incredibly sensitive because those muscles are often forgotten, those adductors. And I wouldn't be surprised if there's a little bit of trouble in those, and they just need to have a little bit of time to relax off. And you may even find that when you're doing some of the squats, for example, that you actually feel a bit of pulling in that inside of the groin, maybe as they're being stretched out a little bit more than they're used to, which would be a good thing.
Okay.
So I'd look at those things.
Awesome. Hope that helps you, Rita. Alex Vesco has said here, I've noticed that since doing the squats and hip flexion extension exercises and also the rotational exercises in phase 3, that I get some hip pain, although it doesn't really affect me at all. I wonder if it is post-exercise ache or whether I've aggravated the sciatic nerves.
If you're getting hip pain on the front, I would say no. But if we are getting sort of, I would more call it sort of glute pain around the back, then those hip hinges, for example, in workout 2 and phase 3, those definitely have the propensity to create a little bit of DOMS. You might also maybe on the rotation, sometimes when people are doing the rotations, they get their hips involved a little bit too much. So as we go to the end, you can get a little bit of cramping in the glutes on the side. We've got glute medius and minimus and TFL, which are some muscles which are kind of, they run in this bit just on the side up here, and those on the side of the hip can also get into a little bit of spasm if we're really working hard on those, and sort of that post-exercise soreness type thing. So it could well be that. I would say that's more likely, especially if we've been ramping up the intensity a little bit. See how they feel with the stretching. Maybe there's a little bit more noticeable stretching when those symptoms are there, when we're doing sort of the glute stretches, etc. And that may be an indication there's a little bit of DOMS that just needs to be worked out.
Okay, awesome. Kate has asked here, she said, while doing the side planks, I find it uncomfortable lying on the right side over the hip area. Likewise, when lying on that side on a firm surface. Could this be where the right leg is slightly longer than the left leg, so the muscles are weaker in that area?
So generally speaking, on the longer limb, we put more load, and therefore it's more likely that the muscles are going to be a little bit stronger on that side than the other side generally. But that's not all the case, and I'd say, maybe 70% of the time that's true. But what I would say is that the feeling of lying on it's this part that's actually sore may well be because maybe those muscles in the legs aren't as good as or haven't been historically as good as they should have been. And you're getting a little bit of flicking, maybe a little bit of bursitis over here because that snapping over the side may be occurring on a daily basis. And that's something where as we improve the strength and stability of those muscles, it'll calm down. You may find a little bit, a small amount, not the same as the lower back, but a little bit of icing just over here. Remember, this is quite close to the surface of our skin. It's not like our lower back where the vertebrae are really deep, so we need the ice on for a little bit longer. A couple minutes max just over here. You might find that doing that sort of a couple times a day for a few days might make those exercises a little bit easier for you.
Yes, could it be the fat pad that you were talking about?
It's not a fat pad, it's the bursa there.
Okay. Joe has asked here, does a reduced range of motion in the squat just mean that more stretching of the hip muscles are needed to be done?
Yes and no. Yes, in that the hip muscles need a little bit more mobility, and that will come with things like the flexibility program. But it also likely means there's a lack of strength. The nice thing about using the squat as the evaluation point is it combines flexibility with balance and strength all into one test. So you cannot do the squat well if we don't have strength, but maybe if we have flexibility but we don't have strength, we're going to just kind of collapse into the squat, and it's very, very obvious that that's occurring. Doing the squat correctly well requires that balance, it requires that strength, and it requires that flexibility at the same time. So you'll find that if you're missing any one of those, if you're really, really strong but stiff, you're not going to be able to do the proper squat. And if you're really, really flexible but have no strength, you're going to collapse when you go into those ranges of motion. So it's a fantastic test, which is why it's in there on the flexibility program, to actually assess more accurate functioning of these muscles, because they all have to work together. Some of them have to be more flexible, but some of them have to be strong and stable. And that it's a really good one as a test.
Okay, wonderful. I think that is everything. Alex Vesco said excellent thanks. Kesa, thanks so much. Brilliant. Thanks everyone for your questions. Really hope that was valuable.
Yeah, I hope it was interesting. And if you guys have any further questions, do post them in the comments below. One final sort of thing for today. Next week, we'll be approaching our 150 live streams that we've done since March the 23rd. It would be. We've done them every single weekday. And over the next sort of couple of weeks, we're going to be looking to change the way in which we do these to really help the premium members a little bit more. So we'll have some more announcements at some point during the next week on those as we race towards 150, or episode number 150. So we'll be changing things up. Pretty exciting stuff coming alongside that. A few other bits and pieces as well, which we'll make announcements for next week. So with that out of the way, hopefully you guys have found this video really, really helpful. And again, if you do have any questions, please do post in the comments below. Thank you to all of you guys that did ask questions. They help not only you, but they help everyone else, and they make it more fun for us and keep me definitely on my toes. So thanks so much for that, guys. Have a great weekend, everybody, and we will see you on Monday with another live stream. Thanks so much for joining us on today's video. Hopefully you found it packed full of useful information. If you want to learn more about the premium Back in Shape membership, there's going to be a video somewhere underneath here. And if you want to stay up to date or tune in to some of our more recent live streams and the Q&As at the end of those, then that's going to be down here. And remember, you can subscribe to the channel up here and hit the notification bell to make sure you know when we next go live, so you can join us for our next live stream and Q&A.